Hi, everyone, and welcome back to another episode of CHD Unpacked, a podcast about living with congenital heart disease. This podcast is brought to you by the Canadian Congenital Heart Alliance. I'm your host, Amanda, and today we'll be unpacking the topic of congenital heart disease and pregnancy. We're very honored today to be joined by our guest, Dr. Candice Silversides. Dr. Candice Silversides is a professor of medicine at the University of Toronto, the Miles Nadal Chair in Pregnancy and Heart Disease, and the director of the Cardio-Obstetrics program at Mount Sinai Hospital. She works at Mount Sinai and Toronto General Hospitals, specializing in pregnancy and heart disease and adult congenital heart disease. She's the editor-in-chief of the Journal of the American College of Cardiology Advances. She has published extensively in the field of cardiology and contributed to many of the international practice guidelines related to adult congenital heart disease and pregnancy and heart disease. She was awarded the Canadian Society of Cardiology 2023 Achievement Award for her contributions to the field. Without further ado, we'd like to welcome Dr. Candice Silversides. Hi, welcome, Dr. Silversides. Thank you so much for joining us today.
Oh, hi. Thanks so much for allowing me to be with you.
Great. So just to get into the episode, today we're going to be talking about congenital heart disease and pregnancy. Can you start off by telling us a bit about the scope of your practice?
Sure. I'm a cardiologist and I work at the University of Toronto. I have two interests in my cardiology practice. One is adult congenital heart disease, and the other is pregnancy and heart disease. So those two overlap quite a bit, and it's not uncommon that in my pregnancy and heart disease clinic, I also look after individuals who have congenital heart disease, but those are my two areas of expertise.
Thanks so much for sharing that with us. Can you speak a little bit to CHD in pregnancy, if there's specific types of CHD that pose a greater risk to women who are getting pregnant?
Yeah, so the issue with pregnancy, just to maybe take one step back, is that pregnancy puts a stress on the heart. And that's because you pump extra blood during pregnancy. You pump blood both to yourself, but also to the developing baby. And so the heart works extra hard, and sometimes that can result in heart complications during pregnancy. I guess the good news is, despite the fact that that's happening for 9 months straight, the vast majority of women who have heart conditions do well during pregnancy. So mostly it's good news. However, there's a few conditions where that extra stress of pregnancy sometimes can result in complications. So by complications, I mean heart complications such as arrhythmias, which are fast heartbeats, or heart failure, which is when your heart doesn't pump as effectively. And as a consequence, your body starts to retain fluid, including fluid in the lungs. So the types of conditions where complications are more common are related to, there are just a handful of conditions, but one is if you have a very weak heart. Now, many people will have some mild weakness of their heart, and that tends not to be as problematic, but if your heart is very weak, if your heart valves are very diseased, if they're not functioning properly, specifically if they're not opening well, we call that stenosis. But if you had severe stenosis of some of your valves, it can be associated with increased risks of complications. If you have an enlarged aorta, so the aorta is a big blood vessel that leaves the heart and delivers blood to the body. If that is enlarged to a significant degree, it can stretch even further in pregnancy and give you troubles. And also if you have pulmonary hypertension. So pulmonary hypertension is high blood pressure in the lungs. So again, I'm just going to recap: weakened heart, severely weakened heart, severe valve disease, stenotic valve disease, pulmonary hypertension, aortic disease. There are also some complex congenital heart lesions that may have problems tolerating that stress of pregnancy. So for instance, just as example, if you had a Fontan operation and had been having troubles because of your Fontan your Fontan circuit was maybe not working as well as it should, and you were developing, saying you had been having troubles with heart failures or recurrent arrhythmias, that may be a scenario where the extra stress of pregnancy is problematic for you. That one does require input. Well, they all require input from your cardiologist because every individual is unique, um, and every story, it's not always quite so simple as a bucket list. So
Mhm.
it's really critical that you do talk to your cardiologist and find out, are you good to go for a pregnancy? Are there things you might want to do to optimize yourself before you get pregnant? Or do you have one of those conditions where pregnancy really would be hard on your heart?
Okay. And just to clarify, within these categories
Yeah.
of potential risk that you've outlined, do they kind of lie on a spectrum in terms of when you would categorize them as, more
Yeah.
risky? So, for example, someone with a mild stenosis versus a more severe stenosis, is
Yeah,
pregnancy
that's
more of a
that's a great
possibility?
question. I'm only talking about severe condition, so severe stenosis, severe weakening of the heart, really pretty severe enlargement of the aorta. So the milder forms of most heart disease do well during pregnancy. It's
Okay.
really only when things have gotten to a more advanced stage that sometimes the stress of pregnancy can be problematic. But again, there is a large spectrum and there's a lot of variability. And so it really is important that you and your cardiologist are talking about this.
Okay. Thanks for outlining all of that. And just to touch on the piece about pulmonary hypertension that you
Yeah.
were referring to, are there certain types of lesions that are commonly known by the CHD community that can then translate into someone having pulmonary hypertension?
Yeah, so there are. That's another great question. The classic conditions that are associated with pulmonary hypertension are ventricular septal defects and atrial septal defects. But and sometimes in patent ductus arteriosus, if it's very large and has been long-standing and affecting again the lungs, because again pulmonary hypertension is high blood pressure in the lungs. So those are the classic ones. But certainly, I would just like to say that most people with atrial septal defects or ventricular septal defects or patent ductus arteriosus, most people do not have pulmonary hypertension. That's actually kind of a rare association to also have pulmonary hypertension, but those are conditions where we sometimes see it. We also do sometimes see it in more complex congenital heart lesions, but again, it would be rare.
Okay. Okay. Thank you for making that distinction. And in terms of the risks that, on the severe end of the spectrum, the risks that women may face, you mentioned heart failure. Can you kind of give a picture as to the progression of what that might look like for someone that could develop heart failure and what their prognosis might entail?
Yeah, so I guess the good news is most will not develop any heart failure, but heart failure again is when the heart can't pump as effectively. And sometimes it's because during pregnancy, it's having troubles dealing with the stress of pregnancy. Most of the time, that results in an accumulation of fluid in the lungs that makes you short of breath. But sometimes you can have fluid simply accumulate in your feet or your belly. So the fluid can accumulate in different spots as part of that heart failure syndrome.
Hmm.
Um, the good news is most of the time we can treat it with medicine. So you might have heard of water pills. Water pills are a way to get you to pee out the extra fluid that you're accumulating. And
Hmm.
sometimes we use other different types of medications as well. We have to be safe during pregnancy, and we only use medications that are both safe for the mom but also safe for the baby.
Right.
And some of the medicines we use for heart failure outside of pregnancy aren't safe to use during pregnancy. So we also have to tailor the type of treatment we use, but mostly the fundamental thing is to clear the fluid, and mostly that's done with water pills.
Just to kind of transition into some other common complications that might result in a pregnancy outside of the context of CHD, such as preeclampsia and gestational diabetes. These are two significant complications, and there are recommendations for guidelines to screen for these conditions in pregnancy. Do these guidelines change in a woman that has CHD? Or are there things that you might look out for a little bit sooner or different red flags you might see?
Yeah, so preeclampsia, just for everybody listening, is really a dangerous high blood pressure condition where it doesn't just cause high blood pressure, but it can also affect organs like the liver, the brain, other organs, and it can be dangerous for the mom and the baby.
Mhm.
So I'll kind of start with preeclampsia. So I think the screening for preeclampsia is primarily to watch your blood pressure throughout pregnancy. So any woman that has been pregnant will have been aware that their blood pressure will have been checked many, many times. Always at the obstetric visits, they check blood pressure, and certainly when you see your cardiologist, the blood pressure will be checked. And that's because if the blood pressure starts to rise, sometimes it can develop into preeclampsia. So preeclampsia is kind of the end stage of really advanced high blood pressure. Now, we don't screen for it any differently if you have pre-existing heart disease. So you still would be having frequent blood pressure checks throughout pregnancy, whether or not you have heart disease. If your blood pressure ever goes up and it starts to look like something isn't right, then you often get extra tests, blood tests, and you get your urine checked to see if there's protein in your urine. One of the kind of classic findings with preeclampsia is high levels of protein in the urine. But again, that all really is going to be part of routine care. But the reason perhaps preeclampsia is important if you have heart disease is that that high blood pressure could be extra hard on your heart if your heart already is not in 100% great shape. It just may be harder on your heart. So, certainly we don't screen any differently, but we really are attentive. If blood pressure is creeping up, we make sure we get on top of it. We make sure we're aware that that screening should be done frequently, and we follow the recommendations, but pay extra attention to blood pressure in our patients. In reality, what happens more commonly during pregnancy, yes, you can develop high blood pressure, but it's not uncommon for your blood pressure to actually go a little bit low, especially early in the pregnancy. The hormones of pregnancy and the fact that now you've got a placenta and the blood flow kind of changes throughout the body, you tend to drop your blood pressure a little bit, especially early in the pregnancy, and then it creeps up later. But the reason I mention that is because although preeclampsia is important, sometimes women will also have troubles with lowish blood pressure and dizzy spells, and sometimes we have to address that as well. In regards to gestational diabetes, so that's diabetes you develop during your pregnancy. Again, we don't screen any differently. It is part of routine pregnancy screening that all women will have a test for diabetes, somewhere usually between like 26 and 28 weeks into the pregnancy. If they have high risk features, so if they've had it before, or for instance, or if there's a number of other high risk features that we would look for where we may screen a little bit early if we think somebody's at higher risk to get it, so we pick it up earlier and tackle it. But we don't do the screening procedures any different if you have most forms of heart disease. However, what I would say is, when you have a heart condition, you already know that things could impact your pregnancy, your health, the health of your baby. So I think it's really critical that you remember that any other medical conditions that you can get on top of and treat effectively and pick up early and make sure you don't get complications from them. It's really important to be all over that screening because the last thing you want is to have to worry about your heart and another medical condition.
Mhm. I think that kind of speaks to like the holistic care that
Yeah.
someone is aiming to achieve just in their health in general, whether or not they're focusing on their pregnancy or beyond pregnancy. I think that's a great point to highlight to just be able to be aware of everything that could potentially have an impact.
Yeah, I agree with you, Amanda.
Yeah. And just transitioning now into delivery stages for a woman. So if she has now made it throughout her entire pregnancy and she's starting to think about the method of delivery that she might have, are there specific guidelines for women with CHD in terms of whether a vaginal delivery or a C-section might be a better choice?
Yeah, so another great question. All these are really, really important things because they're very common questions that people have.
Mhm.
Uh, in regards to delivery, first of all, there are medical guidelines out there that tell you what type of delivery is optimal. But I will tell you the general principle is that a vaginal delivery is always easier on your body than a cesarean delivery. And that's because you're at less risk for complications with a vaginal delivery. So there's less chance of losing a lot of blood, so bleeding complications, less chance of developing blood clots, less chance of getting infection. It's just less things happen with a vaginal delivery.
Mhm.
Now, the majority of women with heart disease will have vaginal deliveries with some rare exceptions. There are a few times where we might consider a cesarean delivery. So, for instance, if you had pulmonary hypertension at some centers, you might have a cesarean delivery. We don't necessarily do it routinely at our center, but some centers are more inclined to do it. If you have very weakened heart muscle, if you have a lot of ventricular dysfunction, that would be the medical term for it. If the heart was really weak, you may consider it. You also might need a cesarean delivery if you were on a blood thinner like warfarin that wasn't stopped well in advance. It needs to be stopped and cleared from your system, warfarin specifically. And if that didn't get stopped, you might need a C-section just to prevent bleeding as the baby goes through the birth canal. But as I said, it's really most of the time and almost all heart conditions, the optimal strategy is to do a vaginal delivery. Now, that doesn't always happen in real life because there's many obstetric reasons you might need a cesarean delivery. So, if the baby's not descending, then you need a C-section because the baby somehow needs to get out. So there's a lot of times women have cesarean sections because they have an obstetric indication, but usually from a heart point of view, the best bet is a vaginal delivery, unless you've gotten really sick or you have one of those few rare conditions I just mentioned.
Okay, that makes sense. And, you know, I think sometimes it's important to look at a C-section in the context of it is still major surgery. And
Yeah,
sometimes it's not viewed in that way.
yeah, no, that's exactly how you should think of it. It is major surgery, and major surgery is always trickier if you have a heart condition. And that's conceptually, I think, the best way to think of it. Now, the interesting thing is, I would bet 70 or 80% of patients with congenital heart disease, pregnant patients with congenital heart disease, have had somebody tell them they need a C-section for at the time of their delivery. Somehow that's just been passed around through years. Everybody seems to think if you have heart condition, you automatically get a C-section, but it's just simply not true.
Why do you think that misconception exists?
I think everybody thinks it's easier to somehow just do surgery and surgically take out a baby instead of push out a baby. But
Mhm.
again, it's major surgery to have your abdomen cut and a baby taken out. And
Yeah.
I think people overlook how big the surgical part of a C-section is.
For women that do have CHD and have developed cardiovascular complications as a result of their pregnancy, do you have any advice for them both during the pregnancy, some things that they could potentially do to get help and even after the pregnancy?
Yeah, well, first of all, I hope you do your best to get hooked up with your cardiologist or a cardiologist that knows something about pregnancy, so that they can follow you throughout pregnancy and keep an eye on you. But if for some reason that hasn't happened, and you develop what you think is a cardiac complication, it would be really important that you get in touch with or get referred to a cardiologist that again has some experience with dealing with cardiac complications in pregnancy, because it really is important that you're treated properly, that you're treated with medications that are safe to use during pregnancy, and also you want to be optimized before you go deliver your baby. So if pregnancy has been a little rocky, you really want to make sure you're treated in the best possible shape before you go and deliver that baby, because you don't want to run into troubles then. So again, the general principle is make sure you're in the hands of somebody that can look after you if you start running into troubles. If it occurs after pregnancy, or sorry, if it occur, the issue is like, what do you do if you've had troubles in pregnancy going forward? What I will tell you as a general principle is if you've had troubles in pregnancy, it probably means you're kind of at more risk for developing problems over the next year or two because you've recently had a complication. And so you really, again, want to be under somebody's care that can make sure you're being that make sure somebody's checking in on you periodically, maybe even a little more frequently than usual, tweaking any medications if medications need to be tweaked, and just making sure that you kind of sort out that rocky trajectory.
Okay. And how often would you recommend women be seen by their healthcare provider?
During pregnancy?
Yes. Yeah.
Yeah, so during pregnancy, I would say, it's not uncommon. We see patients at least once a trimester. That would be kind of just very general, check on people early, maybe in the second and the third trimester. If they have a very simple cardiac lesion that maybe isn't associated with much risk at all. You may even just see them in the see them early and just check in and make sure all is well, but you might just see them before they deliver to check in. But if it's anything that's more complicated, anybody that's having any complications, you follow them much more frequently. So if you're worried about somebody's health, you might see them on a weekly basis. It's just we try and tailor it to how complex the heart lesion is and how women are doing, because ultimately we also don't want to inconvenience people if we don't have to, but certainly it could ramp up to weekly if need be. And I want to say one more important aspect of follow-up during pregnancy. It's really important that people check in with you during the course of pregnancy and treat any issues should they arise. But it also is important to remember that you also need to be seen after you deliver, because even though you've delivered your baby, your heart doesn't really drift back to its complete normal baseline state for many months after you deliver. So even early after delivery, you're still at risk to develop some complications. And so it's important that, again, your cardiologist checks in with you after you deliver just to make sure nothing new is arising after the delivery of the baby.
Okay. And I'd like to clarify these visits that you're talking about, that is in addition to when they would be seeing their obstetrician as well for other routine checkups related to just the pregnancy itself.
Yeah, good point. So these are just separate visits with your cardiologist.
Hmm.
Actually, when you see your obstetrician, they will follow you much more closely for the most part, because they have a progressive incremental increase in how often they see you. It starts out monthly, but by the end of your pregnancy, they're seeing you weekly. And so usually your cardiologist, especially if you're stable, won't be seeing you that frequently. So you've got two visits to coordinate. Well, you've got other visits to coordinate as well. If you have a heart condition, you likely will also see an obstetric anesthetist prior to delivery, so they can talk about how to kind of minimize the pain and manage pain during the delivery to make the delivery a little easier on you and your heart.
Yeah. Well, that's great to know for first-time mothers or mothers that are, in the planning process, that you will have multiple levels of care that will be involved throughout the pregnancy, and there's lots of opportunity to ask questions and kind of better understand what to expect throughout the process.
Yeah, I think it really is helpful to kind of have a sense of what you're getting into, so you can kind of plan your life, because it's tricky to have a number of visits. And so at least if you know what to expect, you can kind of get a team around you to figure out how you can make it work, or
Hmm.
notify people at work, or if you're in school, figure out how you're going to work around your school schedule.
Yeah, and I think the more information going into the process is better, both from a reassuring standpoint and to better plan healthcare outcomes throughout the pregnancy.
Yeah, there is no doubt about it. The more you know, the better off you are.
Yeah. Well, thank you so much for giving us all this information and helping women with CHD plan this really important and exciting stage of their lives. So, on behalf of everyone from CCHA, we just wanted to say thank you, Dr. Silversides, for joining us today.
Well, thank you for inviting me to be here. As I said, I'm really honored.
Great. Thanks so much, and we'll see you on our next episode.
Great.